Okay. Going to wait another minute and let's see if other people join us before we get started. Everybody have a good break, short break, but a good break. I went to Utah and Arizona and hiked 48 miles. So it was a lot of hiking. It was beautiful country. We went to Zion National Park, Bryce National Park, Antelope Canyon, which is a slot canyon. Hold on, Alexa is listening to me. I've never had that happen. Alexa started asking about national parks. Yeah, I didn't even say Alexa. And we went to South Rim and Grand Canyon, so it was fun. Okay, I'm going to go ahead and get started, and we are recording. So if you have to leave or something, you can watch it later. And tonight we're going to talk about evaluation and management of chest pain in primary care. This is a very common complaint that you'll see, and there are a lot of causes, so we're going to go through them one by one. So chest pain, like I said, is a very common complaint in the primary care setting, and there are a lot of conditions that can range from very minor to urgent and life-threatening. So it's important for you to be able to accurately assess a patient with chest pain and distinguish which ones can be treated in the office and which ones need to be referred to the emergency room or specialized care or even hospitalization for further evaluation. So what are some of the causes of chest pain? What are some things that you might see in primary care that cause, generalized pain in the chest? Reflux, real big one, GI. MI, obviously, anxiety. Anxiety is a big one. Costochondritis and muscle pain. So musculoskeletal is a real frequent one. Those are probably the big three. Pneumonia, MI says pneumonia. Respiratory complaints definitely can cause some chest pain. So let's go through these one at a time. So some common causes, musculoskeletal or chest wall pain. This can be due to things like costochondritis. It can be, due to a pulled muscle or inflammation from an infection, different things like that. Gastrointestinal disorders, anxiety and psychiatric disorders, respiratory disorders, and then the cardiac issues, stable angina, non-ischemic cardiac disorders, and then inflammatory disorders or infections. Okay, so some causes seen in the urgent care or ER, where people self-select to go there or are sent there, are usually going to be a little more serious. Unstable angina or acute coronary syndrome, pulmonary embolus frequently presents with chest pain, pneumothorax, esophageal rupture, and aortic dissection. And approximately 50 to 60% of patients in the ER with chest pain will be diagnosed with a non-cardiac cause. And most of these are going to be either musculoskeletal, chest wall pain, GI disorders, or psychosomatic disorders. So this is just, you don't have to memorize this or anything, it's just kind of some information. And it's a breakdown of the epidemiology of chest pain in primary care versus the emergency room. So you can see in, my mouse is just not working well today, that in primary care, almost 40% is going to be musculoskeletal, followed by about 20% GI. And then, serious cardiovascular disease is going to be only 16%, 8% for psychiatric, 5% for pulmonary and 16% for nonspecific. When you get over to the ER, you've got, well, like ER over here, 54% is going to be serious cardiovascular disease. So urgent care, well, this is primary care in Europe. I guess I don't know why they don't have any unstable coronary artery disease there. But in the emergency department, you can see that, the serious cardiac disorders are probably going to self-select and go right to the ER. But I've had people come to primary care clinics having MIs, so you never know. Okay, so where do you start? And the most important thing, as in with all your patients, is a careful history and physical exam. And especially with chest pain, you want to do a risk assessment. So you want to do a really careful assessment of what risk factors does this person have for cardiac disease, and that would make cardiac disease a more likely diagnosis. You want to do focused testing. You're not going to take everybody that walks in the office to have a stress, with chest pain, to have a stress test that day. So you want to try to narrow it down and see which direction you need to go, and then obviously referral to a specialist or hospital if it's required. Melody asked, I noticed that from the tables from 1994, does it seem to be about the same percentage in the U.S. currently? I don't have a current table to show you, but I imagine that it's very similar, because in primary care, the things that are, the GI and the musculoskeletal tend to go on for a longer period of time and are not usually as sharp and acute feeling, so the patient will probably go to see their primary care. Somebody that's having an acute MI, if they're having the typical one that you think of, with the crushing chest pain, they're going to go to the emergency room. So they're not going to, wait. So things like, aortic dissection or esophageal rupture or any of those are going to have such severe and acute symptoms that they're going to go to the emergency room. So let's first look at some non-cardiac causes of chest pain. And we'll look at musculoskeletal disorders first. And the most common, this is the most common non-cardiac cause of chest pain. Almost 40% of patients with chest pain have some kind of musculoskeletal disorder or chest wall pain. This chest wall pain is most commonly caused by muscle strain or by costochondriasis, and less commonly by things like broken ribs. Herpes zoster, and I'll show you a picture of that in a few minutes, can cause chest wall pain along that dermatome. Fibromyalgia causes kind of a generalized pain in joints, and you have a lot of joints in your chest. You've got your shoulders, you've got the clavicles, the sternocleidomastoid, you've got all different joints, the joints of the ribs where they attach to the sternum and everything that in someone with fibromyalgia can cause pain. Fibrocystic breast disease. Some people experience sharp shooting pains in the breast, and if the breast happens to overlie the heart, then they can be confused by that. Sickle cell crisis is usually caused when the sickle-shaped cells clog a small artery or a capillary, and obviously that can occur in any part of the body. Pulmonary embolus is common with that, different things that are in the chest. Chest wall contusions from trauma or protracted vomiting can cause tears in the esophagus, Mallory Weiss tears, and cause some chest pain in the esophagus. Chest wall pain is going to be, or musculoskeletal causes of chest pain are going to be more common in active adult young patients that are involved in sports or in work that involves lifting. Sometimes, you'll get somebody like a painter that's been, painting up over his head all day, pushing a pole with a roller on it up and down and come in with chest pain. And it's really just the muscles of the upper chest that have gotten inflamed. Some risk factors, obviously trauma, overuse injury, like, a painter or, gymnast or anybody that's training for anything. History of chickenpox, which would put them at risk for shingles or herpes zoster. You want to look at the character and the location of the pain. It ranges from sharp to dull, and usually it is more localized and can be pointed to with a finger. Most of the time with cardiovascular or cardiac origin chest pain, they, put their fist over their chest, or it's in a generalized area of the upper chest. But with musculoskeletal pain, a lot of times they can point to a certain area. It's between these ribs over here on the side. It's real sharp pain over there. It's more localized. With herpes zoster, they usually describe burning and pain along a specific dermatome. And dermatomes, remember, start at the spinal cord and go around. They follow the nerve root, and they usually do not cross the midline. So the pain will usually be localized on one side, as will the rash. And I'll show you the rash in a few minutes. Aggravating factors, musculoskeletal chest wall pain is usually made worse with arm movement or anything that's using those big muscles, or deep inspiration. Sometimes if it's costochondriasis, the deep inspiration where you're going to be stretching those muscles between the ribs will cause pain, or twisting movements, leaning to the side or bending over. Anything that stretches those chest muscles will make musculoskeletal pain worse. Duration is usually more of a gradual onset and a longer duration. And on physical exam, chest wall pain is often reproducible just by palpation. So if you palpate over the trapezius muscles in the back, and they say, oh, that's where it hurts, and it goes right through my chest. So, or the muscles of the upper chest or something like that will reproduce that pain. Ligaments and the costochondral joint border, where the ribs join the sternum, a lot of times those are tender to palpation in costochondriasis. And then you want to examine the skin for any rash that might be associated with herpes zoster. And the pain of that develops before the rash, a day or two before the rash. So they'll complain of this, terrible burning pain, and you don't see anything, but a lot of times the next day they'll break out in that rash. So you always want to ask about that, history of chickenpox, and they can still get that even if they've had the zoster vaccine. It makes it less likely and less severe, but it does not completely stop it. Tests, usually none are indicated for musculoskeletal pain unless there's a history of trauma, and then you want to get a chest x-ray or chest x-ray with rib detail if you're thinking that maybe they've broken a rib. Treatment would be rest, anti-inflammatories, ice, or heat, whichever one the patient prefers. Try to get them to use ice at the beginning, but a lot of people can't tolerate that. This is a typical shingles rash from herpes zoster on the chest. If you saw the whole patient, it would start pretty much at the midline, just lateral to the spine, wraps around the chest, and see how it does not go past the midline in the front. So it's following that nerve root that goes around the chest wall. It starts usually as a burning, tingling sensation with no rash. Then the rash develops, and you can see on here that they have little blisters or vesicles, which will then break and crust just like chickenpox does. Very, very painful. They usually need narcotic pain medication. They don't want anything to touch, any sheets or clothing to touch it. It's very painful, and you can give them Zovirax. Let's talk about gastrointestinal disorders. It's another very common non-cardiac cause of chest pain. They account for 20 to 30% of patients with chest pain, and some of the causes are GERD, esophagitis, esophageal spasm, where there's not really irritation, but there's muscle spasm there, peptic ulcer disease, hiatal hernia, and gallbladder disease. And factors increasing the likelihood of a history of ulcers in the past, smokers, because that increases their risk, use of alcohol, and always ask about use of NSAIDs. A lot of people, the nurses in the triage area or the office nurse will often get their medication list, but most of the time patients just think about prescription medicine, and they don't think to tell you that, oh yeah, I take 4 Goodies powders a day because I get headaches a lot. And, right away you can go, ding, that's what's causing your problem. So Goody's powders are terrible. So always ask about over-the-counter medication use. Character and location. GERD is usually described as a substernal burning pain. Esophageal spasm usually presents as more of a squeezing pain or pressure substernally, because that's where the esophagus is running down there. Peptic ulcer disease and pancreatitis may present as epigastric pain that radiates to the back. It will, kind of go through, they'll say it's like a stabbing pain that starts in the epigastric region and goes to the tip of the scapula in the back. This is usually timing and duration. It's usually recurrent pain. It may last minutes to hours depending on the cause. It's usually aggravated by meals or a supine position, laying down, often relieved by antacids, PPIs like Prozac, things like that, or H2 blockers like Xanax. Some of the associated symptoms, nocturnal cough is a common symptom that you see with people with reflux, because that, when they're laying down, the acid comes back up and irritates the esophagus, and sometimes they'll actually aspirate some of that into the upper airway or the lower airways, and the upper airways get irritated by that acid and cause cough. Flatus, belching, dysphagia, difficulty swallowing. Exam findings, there's usually pain to palpation of the epigastrium. And some lab tests that you would do for this would be like tests for H. pylori, maybe an EGD or upper endoscopy to look for ulcers. If you were suspecting something like gallbladder disease, you might want to do a gallbladder ultrasound. And then treatment obviously is going to depend on the cause. PPIs and for GERD, antibiotics for H. pylori if that comes back positive. If it's gallstones, surgery. And then educate them on diet, things like elevating the head of the bed, 30 degrees on blocks or something to help with reflux. Psychogenic causes account for about 10 to 20% of chest pain, and we do see these in the ER a lot of times because they're just so, anxious and convinced that they're dying. Causes include stress-related disorders, panic attacks, and somatization or hypochondriasis. Stress can also aggravate other conditions that cause chest pain, such as GERD, asthma, and angina. So it might be that they're having a panic attack, but it doesn't mean that they don't have another issue going on. Like, if they have asthma and then they come in with a panic attack, they're going to be, they may be clamping down and having pain from that. Or if they have angina, it might trigger their angina. The character and location varies widely, just depending on the patient. Panic disorder, they usually talk about precordial chest pain, and that's why they a lot of times come to the ER because they're convinced it's a heart attack. Depression is often present, and that can be constant or intermittent heaviness unrelated to meals or activity. The timing can be either sudden if they're having something like a panic attack, or gradual if it's due to depression or just generalized anxiety. Aggravating factors, stress, history of panic disorder or depression. Some of the associated symptoms would be anxiety, dyspnea, hyperventilation is real common, tingling of the and numbness of the fingers or toes, usually due to hyperventilation. You blow off so much carbon dioxide that your fingers and toes start to tingle, and dizziness, again, due to hyperventilation. There are two screening questions that are highly sensitive for panic disorder. First is, in the past 6 months, did you ever have a spell or attack when all of a sudden you felt anxious, frightened, or very uneasy? And the second one, in the past 6 months, did you ever have a spell or attack where for no reason your heart suddenly began to race and you felt faint or couldn't catch your breath? If they answer yes to either of those, it's a positive screening. If they answer no to both of those, it makes panic disorder less likely. I've seen, Allison says that she's seen precordial catch syndrome twice in clinic, both with teens, one female and one male. Is that just this summer or in family practice, I guess, because you just started today? Yeah, well, that's interesting. They were both under a lot of stress. So, you know, anxiety disorders, you know, you're going to see those. I hate to stereotype, but female usually more than male, young more than old. So, you know, if you have a 20-something female that is hyperventilating, has the tingling fingers and, you know, and is, you know, her complaining of sudden onset of the heart racing and the pressure and all the other things, you know, it's more likely going to be due to anxiety than it is going to be due to acute MI. Okay, some respiratory disorders. Respiratory disorders cause 5 to 10% of chest pain in patients, and these can include bronchitis, pneumonia, asthma, COPD, pneumonitis, pleurisy. They get very sharp pains with pleurisy, and pulmonary embolism. And we'll talk more about pulmonary embolism in a minute, but some of the risk factors for pulmonary embolism are prolonged immobilization, pregnancy, pelvic or lower leg trauma, hypercoagulability, estrogen use. So that is one of the ones, you know, where if it's a young female that smokes and takes birth control pills, that you would want to worry about pulmonary embolus. And cancer. I had a patient, I'm trying to remember what day it was last week. One day last week, I was working in the ER, and it was in the main side, not in the rapid treatment. Real nice gentleman that was only 63 and had just had 6 weeks ago had a left lower lobectomy for lung cancer, and he was, you know, he said it was, you know, they got a good report, they got all the cancer and everything, and he had gotten up to where he was walking for 10 to 15 minutes without any problem. And over the last couple days, he was getting increasingly short of breath. He didn't complain of any chest pain, but just increasing shortness of breath to the point where he could only walk 5 or 10 steps without having to stop, you know, in the house, not even outside. So we did chest x-ray, and it showed possible effusion versus just filling from where the lobe was taken out, and did a CTA of the chest and a BMP, and his BMP, which you're going to be reading about for heart failure, was 4,466, and he had bilateral pulmonary embolus, you know, both lungs. His biggest risk factor was that he has cancer, so that is, you know, not great, but he obviously got admitted for anticoagulation. So, but he didn't have any chest pain, but he was hypoxic and dyspneic. So, character and location, again, varies depending on what the cause, what respiratory cause. Pneumonia, sometimes they'll have either no pain or dull aching pain in the area of the lobe that's involved. Pleuritic pain, either with a PE or pleuritis, is usually a sharp stabbing pain, and it's usually localized on one side, and it's worse with deep breath or cough. Pneumothorax also is usually a sharp stabbing pain. Timing, PE is a sudden pain. The others are more gradual, you know, pneumonia and things like that. Pleuritis is going to be more gradual. Aggravating factors, usually pain with breathing, deep breathing, or coughing. Some of the associated factors or symptoms might be things like fever, cough, wheeze, dyspnea, hypoxia if you put them on O2 sat, things like that. Some of the exam findings, fever, agaphony, rouse, wheezes on auscultation, friction rub on auscultation with pericarditis, and tachycardia. This man did, with the pulmonary embolus, did have tachycardia. Labs, you want to do chest x-ray to rule out pneumonia, a D-dimer, which is what I was talking about. You look at for DVT and pulmonary embolus, possibly a helical CT, or that's like a CT angiogram to look for pulmonary embolus, and venous ultrasound if they have like leg swelling or leg pain and you're looking for a DVT. You're thinking that they have a pulmonary embolus from a DVT. Sometimes a CTA, that's what we ended up doing on this man. The Wells score is used to predict risks for PE, and I have that on the next slide, and that helps determine what further testing to do. Treatment, pneumonia obviously is going to be antibiotics, and PE is going to be anticoagulation. Pleurisy, there's our pleuritis, really just anti-inflammatory pain medication, because pleuritis is usually just irritation of the nerves of the diaphragm and the pleura, usually after a pneumonia or some kind of respiratory infection, and it just is inflammation. It needs to just go away. So there's not specific treatment if you've already treated the cause like pneumonia and everything. So this is, you don't need to memorize this or anything, but this is the Wells model for diagnosis of PE. Some of the things that you look for, clinical signs or symptoms of a DVT, like leg swelling or leg pain, or pain with palpation of one of the deep veins in the leg. PE more likely, as likely or more likely than alternate diagnosis gets points. So, like, with that man, he had been immobilized because he had surgery and, major thoracic surgery 6 weeks before, and he had a history of cancer. So that right away put PE high on the differential. Heart rate more than 100 a minute, and this man did have that. Immobilization, they say within the last 4 weeks. So somebody that's had a femur fracture or something like that that's in bed. Previous objectively diagnosed DVT or PE makes another one more likely. Hemoptysis, commonly see that with PE, and then a malignancy treated for cancer is either ongoing or has been treated in the past 6 months. So you add up their score, and then less than 2 points, low risk for PE, 2 to 6 moderate, and more than 6 high. This is something you'd see in the, you will see some of these patients in the primary care setting, even with a PE, sometimes they don't have any pain, but they're just short of breath, so they, come to the office. So any questions on non-cardiac causes of chest pain? I'm trying to get through all that before we get to the cardiac stuff. Okay, so let's move on to cardiac chest pain. And we're going to talk about both non-ischemic versus ischemic. So non-ischemic cardiac disorders aren't due to, blockages of the blood vessels going to the heart, like arteriosclerotic coronary vascular diseases. So non-ischemic cardiac disorders are going to be more structural or inflammatory things. So mitral valve prolapse is a common one, especially you see that in young people more. And it's just a floppy, this is a picture of the mitral valve, and the valve, when it closes, usually should close flat, and this is ballooning up into the atrium. This is the chordae tendineae that are holding the leaflets, and they're kind of stretchy or too long, and so instead of the leaflets coming down to open and then going flat, they're ballooning up into the atrium. Usually doesn't cause that much problem, but they can present with chest pain and palpitations, and it can be kind of a chronic ongoing thing. Pericarditis is an inflammation of the pericardium surrounding the heart that can cause sharp chest pains and that friction rub. An aortic dissection, hopefully you would not see this in the office, but I've only seen one in the ER, thank goodness, many years ago. But this is, where part of the wall of the aorta starts to separate and left untreated, obviously they bleed to death. So that's a real emergency. And that's usually a very severe pain, a severe tearing pain is how they usually describe it. And so they, they're the ones that are going to go straight to the ER. And then you have ischemic cardiac disease, which is, disease that's due to clogged arteries from plaque and cholesterol, not enough blood flow getting to the cardiac muscle, causing cardiac pain. So you have stable angina, unstable angina, and then acute coronary syndrome or acute MI. Brittany said she sees them regularly. Is that in an ER, Brittany? I hope. And almost always bad. Yeah, you can have aortic dissection. Can be, you can have a aortic aneurysm that obviously if it dissects and blows, then it's not going to be good unless it happens to happen while they're in the hospital. But sometimes it can start to leak and they can fix it in time. So, but it's got a high mortality rate. Okay, so let's talk about non-ischemic cardiac chest pain. Mitral valve prolapse in most people is going to be asymptomatic, and if they have, if they find it at all, it's because somebody has listened to them and they have that mid-systolic murmur with a click, or for some reason, they do an echocardiogram and they see the floppy valve. So, but for most people, it's going to be asymptomatic and they're not even going to know they have it. But they may have symptoms of nonspecific chest pain, shortness of breath, and palpitations. Some of the risk factors, it's found in up to 10% of healthy females. They're usually thin, tall females. You can have collagen disease such as Marfan's or Ehlers-Danlos syndrome, and they're at higher risk. They have connective tissue disorder. Marfan's, you usually think of, they're tall, they're thin, they have really long arms. A lot of times they're very nearsighted because it affects the muscles of the eyes. A lot of times they have pectus excavatum, or the funnel chest. That's another thing you might see with Marfan's. And those people are going to be higher risk of having mitral valve prolapse. Exam findings, they may have a murmur that can be pansystolic or only a late systole with a single to multiple mid-systolic click. You can look for skeletal changes like pectus excavatum, or scoliosis is another one that's common with that. Diagnosis is confirmed by echocardiogram, and if they're having palpitations, you go ahead and do an ambulatory EKG like a Holter monitor. And then the treatment for that, usually if they're having, difficulty, anxiety, chest pain, palpitations, you put them on a low dose of beta blockers. They're thought to have a hyperandrinergic state, and that kind of calms things down and helps with the arrhythmias. Sometimes SSRIs are used and can be helpful. And then if they have it severe enough to have mitral regurgitation, then they do mitral valve repair or replacement. Melanie, any theories as to why it's found in thin females? Not necessarily. It's just, I don't know if that's just the makeup. Like people with Marfan's are real tall and thin. Not all of them are going to have Marfan's, but I don't know if that body type, the tall, thin body type has more incidence of connective tissue disorders. I'm not really sure why. But, if they did ultrasounds on echocardiographs on all women, they'd find it in about 10% of healthy women. So a lot of people don't even know they have it, and it doesn't ever cause them any problem. So it's just there. Okay, aortic aneurysm or dissection, that's what we were talking about a minute ago. This obviously usually presents to the ER due to the severity of the symptoms. It's a sudden, abrupt, severe tearing or ripping or knife-like chest pain that radiates through. A lot of times it'll be in the upper abdomen because, the aorta goes all the way down, depending on where the aneurysm is, and radiates through the back. And they will usually just say they feel like somebody is stabbing them or ripping them apart. Risk factors, hypertension is a big one. That constant high blood pressure against the sides of the aorta cause the aneurysm to develop. Smoking, congenital aortic defect that they might not know that they had. Inflammatory or collagen disease, pregnancy, and cocaine use is another big one. Exam findings, you usually have a very anxious patient. They have that, sense of doom, dyspnea, hypo or hypertension, depending on if it started to bleed or not. Difference in BP between the right and left arms. Absence of upper extremity pulses if they have an abdominal aneurysm that's rupturing. Harsh holosystolic murmur due to aortic insufficiency, and sometimes paralysis if the blood going to the spinal cord is compromised. Emergent CT and echocardiogram, and obviously surgery. So this just shows an aneurysm that has not ruptured at that point. Pericarditis, the symptoms and exam findings are pleuritic substernal chest pain that can radiate to the shoulders, the back, or the epigastrum. The pain is worse when they lay down. They may have fever and dyspnea, and if you auscultate over the chest, you usually hear a pericardial friction rub. Some of the causes, again, viral infection of viral pericarditis, rarely bacterial, more often viral. Autoimmune and inflammatory diseases like rheumatoid arthritis and systemic lupus can cause this, uremia, cancer, and you can get a post-MI pericarditis several days after an MI. Diagnostic tests, CBC to look for infection, SED rate, again, look for infection. You want to go ahead and do cardiac enzymes to make sure nothing else is going on, an EKG and an echo to see make sure they don't have an effusion or anything, pericardial effusion. Treatment is going to be with bed rest, aspirins or NSAIDs to reduce inflammation. Colchicine is sometimes used, and steroids, again, to reduce inflammation. Alexis said, sorry, just read that tall, thin females, patients with Marfan's, are typically part of a connective tissue phenotypic spectrum. That's the word I was trying to find, phenotypic, that body type, the tall, and they tend to have mitral valve prolapse. So I'm not sure that all of them have Marfan's, but it's that kind of Marfan's like, they're the kind that can eat anything and they're still 120 pounds and they're 5'7", and they just have that tall, lean body type, and they just have increased incidence of mitral valve prolapse. So thank you for that, Alexa, I'm sorry. Ischemic chest pain. I'm going to move on to that. So this is chest pain that's caused by decreased blood flow to the actual myocardium or the heart muscle. We're going to talk about stable chronic angina, unstable angina, and acute coronary syndrome. And this is a spectrum. This isn't a three distinct diseases. This is a spectrum. You can start the day with chronic stable angina and end up with an MI. And so they can fall anywhere on this continuum, and they can kind of go back and forth as the ischemia improves or worsens, depending on spasm or breaking off of a piece of plaque or things like that. So one of the first things you want to do with somebody that you're suspecting ischemic chest pain is a risk assessment. What is their risk for atherosclerotic coronary artery disease? About 37% of patients that experience any acute coronary event, either an MI or angina, will die of it in the same year, and is the number one killer in both the U.S. and worldwide. So, it's a big problem. It can be a chronic problem or a very urgent problem, but you're going to want to, quickly decide whether this is the avenue that you're going to go down. So what are some of the risk factors for coronary artery disease? Smoking, sedentary lifestyle, hypertension, hyperlipidemia, diabetes, obesity, genetics. Great. Diabetes again. I think we got most of them in there. And what's another big one that we didn't say? Okay, well, we've got it right here in front of us. Gender, male gender are at higher risk, but women, it's just as many women die, so it's, you have to consider it both. Age, obviously, risk increases the older you get, and family history is one thing we didn't mention over here. Big risk factor. This is, gender, age, and family history are three things that are non-modifiable. You're stuck with those. You're a 60-year-old male with a father who died at 51 of a heart attack. You've got a high risk. So just based on your gender, your age, and your family history. So always do a family history of coronary artery disease. The younger the onset, the greater the risk. So if someone in their family, brother or parent or uncle died of an MI, at under 55, that puts them at higher risk. Dyslipidemia, obviously high LDL and low HDL put you at risk. And in women only, high triglycerides, those are a risk factor in women. Hypertension, these are going to be modifiable risk factors. Hypertension is a big risk factor. Diabetes, heart disease is the #1 killer in diabetes. Smoking, physical inactivity, abdominal obesity. That's why we always tell you to get that abdominal circumference or do the waist to hip ratio. You have those men that kind of have skinny hips, but they got that big beer belly. That indicates that they have visceral fat or fat around the abdominal organs, and that usually also indicates that they're going to have it around the heart, and they're going to have atherosclerotic coronary artery disease. So it's a big risk factor. Stress can be a big risk factor. A diet low in vegetables and fruit, and excessive alcohol intake. So this is, again, this one's not something I'm going to test you on, but this is called the Ruan decision rule for MI, and it predicts which patients with chest pain and either a normal or non-specific EKG are at high risk for MI. So, again, age over 60, sweating, you see a lot of them come into the ER and they're diaphoretic and they're nauseated and the pain is, pressure in the chest, radiating to the arm or jaw or something, all of those things. A history of MI or angina, obviously, is going to make it more likely that that's what's going on. Male sex, pain described as pressure, radiation to the arm, neck, shoulder, or jaw. And you add up those points, and it kind of gives you a risk of how likely it is to be MI. So let's back up a little bit and just talk about angina first. What are the causes? And most angina, not all, but most angina is going to be caused by atherosclerotic coronary artery disease. Again, that's plaque buildup from cholesterol in the arteries. Vasoconstriction in normal coronary arteries can cause angina, such as that seen in cocaine use or Prinzmetal's angina. And I had another patient the same day, these two patients at the same time, that was 41, that was there with chest pain, and chest pain and back pain, and his O2 sat was low, his heart rate was high, his potassium was like 2.8, and when I did a urine drug screen, he was positive for methamphetamine, cocaine, marijuana, and alcohol. And he had a history of high blood pressure, but he didn't like to take medicine, so he didn't take the lisinopril and hydrochlorothiazide that he had been prescribed. So he didn't like medicine; he liked drugs. But I did. You just had to laugh. I mean, and it was, we got the cardiology consult, we did all that, but we were just, telling him, you're going to kill yourself. He had been in 2 other times in the last 3 months with the same thing. But each time he's positive for cocaine. So, not much you can do other than keep saying you're going to kill yourself. You have high blood pressure. He already had left ventricular hypertrophy on the EKG. But, as long as you use cocaine, your blood pressure, his blood pressure was 182 over 116 when he first got there. And clonidine did nothing. It was like just, twice, taking clonidine twice, never did anything. So until the cocaine gets out of the system, there's not much you can do. But always keep that in mind. If you work ER and you have a young patient that doesn't have other cardiac risk factors, think about cocaine. So you can see vasoconstriction that causes, or vasospasm that causes angina-type pain in cocaine users or in Prinzmetal's angina. And we'll talk about Prinzmetal's in just a minute. Severe aortic stenosis or regurgitation can cause angina. Severe myocardial hypertrophy, increased metabolic demands such as seen in severe anemia or hyperthyroidism. So, if their metabolic rate is just going in overdrive, the heart can't keep up, with supplying that much blood to the myocardium, so they can get angina from that. Arrhythmias due to paroxysmal tachycardia with a rapid ventricular response. Again, they don't have, if they're having a real rapid ventricular response, then they're not going to get enough blood flow to the coronary arteries to prevent having angina. Brady, quit that. Syndrome X is something you don't hear much about now, but they still keep listing it in MCV, so I still keep putting it. And that is normal coronary arteries and no identifiable cause of angina, and it may be due to inadequate flow or in the microvascular. They call it small vessel disease. So chronic, we're going to talk about chronic stable angina. This is the one that's not in the ER, but just coming into the office saying, I just keep getting this, pressure or ache, and it'll come for a few minutes and then it goes away. If, it's worse if I do activity and it gets better when I rest and everything. So you're thinking chronic angina. And so you want to ask about circumstances that precipitate or relieve the pain. It usually occurs during activity and is relieved by rest. That's your typical angina. It's usually worse when they lay down due to increasing the preload and putting stress on the heart. So a lot of times they'll say, I sleep in the recliner if it's bad, or I'm sleeping on 2 or 3 pillows. Activity tolerance may be consistent, or it may vary from day to day. So they may say, I walked, 6 blocks yesterday and it didn't bother me, but today, it was hot outside and I walked a block and I started having discomfort. Angina is often worse after a heavy meal, during sex, with exposure to cold, and in the morning. Those times are more frequent. Strong emotions can provoke angina even at rest. So they may be sitting in the recliner, but they're having an argument with their wife or a heated political discussion with their mother-in-law or something, and they can get angina just due to the stress. Characteristics, it's usually described as tightness, burning, pressure, choking, aching, gas or indigestion, or just a vague feeling of discomfort in the chest. The location usually stays the same for each patient. Different patients may say that it's in different places, but for an individual patient, it's usually kind of consistently in the same place, usually behind or to the left of mid-sternum. It usually radiates to the left shoulder or arm, but can also be felt in the right arm, the neck, the jaw, or the back. Duration angina caused by exertion usually stops pretty promptly with rest and lasts less than 3 minutes. So, ask them, what were they doing when they started having the pain, and, did you go sit down? How long did the pain last once you sat down? I was climbing the steps and I just sat down on the steps and the pain went away, things like that. For angina provoked by a heavy meal or by anger can last longer, like 15 or 20 minutes. And angina lasting longer than 30 minutes is unusual and suggests that they've moved to an unstable angina or acute MI. and so those people need to be in the ER. Nitroglycerin, you can use it. The diagnosis of angina is supported if nitroglycerin relieves or shortens the attack, or if prophylactic nitrates allow greater exertion without attacks. So, they take nitroglycerin and they can walk, 3 blocks where before they could only walk 1 block. So that kind of gives you some indication that it's probably angina that's causing the pain. Physical exam findings, often you're not going to find anything. It's difficult to find much because most attacks are so short, and it happens, they sit down, it gets better. So they don't usually occur during an office visit unless you have them doing a stress test or something. And the history is going to be the most important part of the diagnosis, when it's occurring, how often, precipitating factors, relieving factors, and then there are risk factors for cardiovascular disease. You may find if you do happen to catch somebody that's having angina, if you work in an urgent care or they come to the office with chest pain, you may find elevated BP, apical systolic murmur, or a gallop rhythm due to mitral regurgitation or arrhythmias. And you want to always, do your risk factor assessment for arteriosclerotic coronary vascular disease and document whether they have other conditions such as hypertension, diabetes, or thyroid disorders, because all of those things can increase it. So workup for chronic stable angina, you would want to do labs, a CBC to look for anemia, lipid panel to look for dyslipidemia, cardiac enzymes, and this would only be if they are having pain at the time of the visit. Otherwise, you wouldn't do cardiac enzymes. Hemoglobin A1C, look for diabetes, TSH to screen for, I listed them then I said this. So TSH to screen for hypo or hyperthyroidism. So basically you're screening for anemia, dyslipidemia, diabetes, and thyroid disorders, and rule out acute MI if they are having pain with the cardiac enzymes. EKG, a resting EKG may be normal or may show signs of an old MI or nonspecific STT wave changes or left ventricular hypertrophy if they've got history of hypertension. During an attack or with asymptomatic ischemia, you can get horizontal or downsloping ST segment depression that reverses when the ischemia resolves, and you can get T wave flattening. And then ST segment elevation indicates more severe ischemia and is also seen with coronary vasospasm. Where do you go from here? Again, we go back to the risk factors. Determine the pretest probability of coronary artery disease as the cause of the pain by looking at the risk factors for coronary artery disease. Do they smoke? Are they obese? Do they have hypertension, diabetes, dyslipidemia, all those things? Are they male sex? Do they have a positive family history? Add up all those risk factors to see whether, if all those are negative, then, you're probably thinking this might not be angina. But, most of the time, those are going to, a lot of those risk factors are going to be positive. Your history, how the pain occurs, what precipitating events are, what relieves it, exam findings, labs, and EKG. Refer to cardiology for further testing, but know what they'll do so you can educate the patient. So we're going to talk a little bit about the testing that they will do with the cardiologist, but you're not going to, you're probably not going to do it as a primary care. Sometimes, they will send patients for a stress test or something from primary care, but if they're not actively having chest pain and they're evaluating for stable angina, they're probably going to send them to a cardiologist for evaluation. But, you want the patient to know, what are they going to be doing. So non-invasive, low to intermediate pretest probability. So, you're thinking maybe, maybe not, you're not zooming in on this is definitely angina. You want to start with non-invasive testing. Stress testing is most common. used to confirm a diagnosis of angina, to determine the severity of the limitations, because they'll put them on the treadmill and see how, at what level they start to have pain or EKG test changes, assess the prognosis, and also used to evaluate response to treatment. So if they give them nitro and see how they do with that. Exercise stress testing is not recommended for asymptomatic patients to screen for coronary artery disease because it has a high false positive, unless they're at special risk, like airline pilots. I think beginning at 40, they start having annual stress tests just to look for asymptomatic coronary artery disease, because obviously having an acute MI in the cockpit is not safe for the rest of the passengers. So, but if they are asymptomatic and they just come in and say, I'm just worried that I might have a heart attack, I want to see if my vessels are okay, so I want to have a stress test. We don't do those just, for asymptomatic people. High false positives could lead to more invasive testing, like, okay, now let's do cardiac cath, and that's not a benign test. So Alexa said they had a patient like this at 4:45 p.m. in the clinic last semester. The lab closed at 5. Even with stat results, they was called to an on-call doc after hours, so we sent them by ambulance to the ER. Turns out she had multiple PEs and a DVT, but if you were in an outpatient facility, unless you can get lab results back very quickly, is it worthwhile to order labs? If you think they have a DVT, like, you have somebody come in with leg swelling, or, there's something that might indicate that they have a DVT, or they have the risk factors for DVT. I don't know which symptoms she was having, but, if they're having shortness of breath or chest pain and they have risk factors for DVT, like they have, been immobile or smoking and taking birth control or something, then, I would send them to the ER, because you can get the whole workup done. If you have any doubt that they're having an MI, then you're going to send them to the ER. I mean, if you think they have unstable angina, their angina is, we're going to go through that in a little bit, but then you would send them. But if you have a patient that is, let's say he's 61 years old, he's overweight, he's got a little bit of high blood pressure, he smoked until 2 years ago, so he's not smoking now, and he's trying to do better, but he doesn't really exercise a lot. And now when he goes out and mows the grass, he has to stop. He says, I kind of get this, pressure right here in my chest, and if I stop and go sit down, it goes away. And it's only happened 2 or 3 times, but I'm kind of worried about it. That's the kind of person you can do the outpatient workup on, and send them to a cardiologist to have the stress tests after you get back, the labs that say he has dyslipidemia and diabetes and everything else. But if you have any concern at all of a patient in a primary care office that you think has unstable angina or is on that continuum toward MI, then you transfer them by ambulance, with ACLS package to the hospital, because they, it can happen quickly. So you're right to do that, Alexa, because, you're not going to get the results back. So Melody says, in primary care setting, if the patient displays these signs and symptoms and we have ordered the testing to be done outpatient, do we still give prescription for nitro home until we have the results for testing? Also, how does patient determine if he needs to go to the ED in between these times? Okay, I think I may have just answered your question about when they should go to the ED. If there's any, if they have chest pain that is changing, that is not being relieved the way it was, I've had this 3 times, and if I sat down, it went away in 2 minutes, and now it's not going away, they need to go to the ER. But you could order the tests, and then the hospital can either redo them or they can try to track down the results. But if it was a stable patient in primary care, yes, you could order tests and go ahead and give them nitro to try, just to have at home, and tell them to use that. But we're going to talk about when they should go to the hospital in just a minute. Okay. So it's different because in the hospital you have everything at hand most of the time. Yeah. Okay. So we're just going to go through some of the testing that can be done, the non-invasive testing. I'm not going to test you on these tests, but just to let a patient know, myocardial stress imaging can be used when the results of resting or exercise EKG are hard to interpret, like if they have had a previous MI and they already have baseline ST changes, or if they have left bundle branch block, then it's hard to see ischemia. They can use it to confirm diagnosis, to localize what area of the myocardium has ischemia, to distinguish between ischemia from chronic to an acute MI, and to assess success of revascularization after angioplasty or surgery. They can do myocardial perfusion, scintigraphy, radionucleotide angiography, stress echocardiography, PET scan, cardiac CT, or MRI. All those can be done, and they're all non-invasive. High pretest probability for coronary artery disease, you're usually going to refer straight for coronary artery angiography. These are going to be used for the stable patients, which you have a low to intermediate risk. But if they have a high risk, we talked back here about probability risk, determining their pretest probability. If you think this is definitely ischemia, then you're probably going to refer them to cardiology for an angiography right away. Okay, so let's go on to treatment of chronic stable angina. So you've gotten the stress test, doesn't show, any major ischemia, but, it shows a little bit with exercise or whatever. But, the cardiologist has said that they don't need, revascularization or anything right now. Treatment for chronic stable angina is going to be sublingual nitro is the drug of choice for acute angina attacks. This is just like with asthma, you've got your rescue inhaler. For angina, you've got your rescue nitroglycerin. So this is going to be used for acute angina attacks. It acts in 1 to 2 minutes. It's available in different strengths, 0.3, 0.4, and 0.6 tablets. You can take it 5 minutes before an activity that's known to precipitate angina. So maybe if sex causes them to have pain, they can take it before sex. If they're going to try to go for a walk or do something like that, they can take it before that. They can also take a tablet at the onset of pain and repeat at 3 to 5 minute intervals. If the pain is not improving after 5 minutes, call 911. If the pain doesn't respond to 3 tablets or last longer than 20 minutes, that may indicate acute MI, and they should go to the emergency room. The nitro is also available in a buccal spray. This is a picture of that, and that may be easier for people that have dexterity issues. The nitro tablets, these are much enlarged. They're very tiny, and it's in a little tiny bottle, and if you have somebody with bad arthritis or something, they may have a hard time, or if they have tremor or Parkinson's, they may have a hard time getting a tablet out of that bottle. And the buccal spray is just a spray that they put in the side of their cheek. And this is a little bit more stable. Nitroglycerin tablets have to be kept cool. You have to change them frequently. Does anybody know what to tell a patient to how they can tell whether their nitro is working or whether it's too old and needs to be replaced? What should they get when they take a nitro? There's one symptom that almost everybody will get, besides relief of their chest pain. They will get a headache, okay? It's a vasodilator, and the blood vessels in the brain are going to dilate, and they get a headache. If they don't get a little bit of headache when they take the nitro, it's probably too old, and it probably needs to be replaced. So, that's one thing you can tell them. So prevention of angina attacks, we talked about the nitro for abortion of pain or of an attack, but how about preventing them? First, try to identify the triggers and avoid if possible. If it's cutting the lawn, then get a lawn service, or get your grandchildren to cut the lawn, something like that. Nitroglycerin spray or sublingual 5 minutes prior to the triggering activity, like we talked about, intercourse or something that they don't want to avoid, but that they need pain control for. And then long-acting nitrates, isosorbide, which is a type of nitroglycerin. Oral tablets can be taken 1 to 3 times a day, depending on the formulation. You can have the long-acting nitro either orally in an ointment or in a transdermal patch. This is the ointment that they're putting on a patch that goes on the skin. It's kind of taped on there, but you can get patches that already have it in it too. Main side effects are headache, which can limit therapy. So sometimes, the amount that they need to control their angina causes headaches that are just too severe. So that's somebody that might have to have different kind of medication. Other main side effects are nausea, hypotension, and lightheadedness, because again, it's a vasodilator. Tolerance does develop with continued use, so they need an 8 to 10 hour period a day without nitrates. So if they're using a patch or ointment like this, then they should remove the patch overnight to give themselves that 8 to 10 hour without nitrates. It's the time that they're the least likely to have angina because they're resting. But if they don't, they develop a tolerance for nitrates and it doesn't work. What other class of medication is contraindicated if patients are taking nitrates? Yes, any of the phosphodiesterase or the erectile dysfunction medications such as Viagra cannot be, Cialis, Viagra cannot be taken with nitroglycerin. So always ask about this drug because not every one of them is going to volunteer that they're taking that. Okay. Beta blockers are another medication that can be used, and they're considered first line for most angina patients. So you might have to use more than one thing. It might be that they're on nitro and beta blocker. It's the only drug that's shown. Brittany asked, have we ever heard of using the nitro patch to treat IV exacerbation? I have not heard that, but it would make sense because it dilates the vessels and maybe the blood would disperse more quickly. But beta blockers are the only drugs that are shown to prolong life post-MI in patients with coronary artery disease. Atenolol, metoprolol, propranolol, carvedil, timolol, and nadolol, which I've never even used, and bispirol are all recommended. You want to avoid beta blockers with intrinsic sympathomimetic activity such as labetalol and pindolol. And these are a good choice for an antihypertensive if it's needed. So, if patient, a lot of these patients are going to have hypertension. So you kind of kill 2 birds with 1 stone, treat their hypertension with a beta blocker, and it also helps to control their angina. And obviously beta blockers, Midori asked, what if they also have COPD? So obviously beta blockers are contraindicated if they have severe bronchospastic disease, such as asthma. Most patients with COPD don't have as much bronchospasm as they do inflammation. But if they do have bronchospasm, then you're not going to use a beta blocker. If they have bradyarrhythmias, remember, beta blockers slow the heart rate down. So if they've got, a heart rate of 60 or less, you're not really going to want to put them on a beta blocker. Or if they have decompensated heart failure. We're going to talk about heart failure next week. And beta blockers are used in heart failure, but only in compensated heart failure once the fluid overload is taken care of with diuretics. But they will make decompensated heart failure worse. Okay, so what if the patient has severe asthma or they have heart block and their resting heart rate is 52? Then what can you give them? Calcium channel blockers, okay, those are going to be third line. They're pretty much, I would be real desperate to give a calcium channel blocker to anybody, okay? There you go. And Anataya has it. Ranolazine, okay? That would be a perfect person for ranolazine. This is another first line for chronic angina. It's probably more expensive because I don't think they have a generic alternative. But two things, it doesn't have any effect on blood pressure or heart rate. So if you've got a patient that's, that's had heart failure, and because they have a low ejection fraction, they always have hypotension, and because their heart just isn't pumping very well, or they have they've had an MI in the past and it's damaged the conduction system, and they've got a bradyarrhythmia. So ranolazine does not have an effect on blood pressure or heart rate. Beta blockers are going to decrease heart rate, and they're also going to decrease blood pressure. So it'd be good for those. It's also good for patients that have, bronchospastic disease like severe asthma or something that couldn't use a beta blocker. It can be used as a monotherapy or in addition with other antianginals. It is safe to use with erectile dysfunction medications. It can prolong the QT interval, so it's contraindicated in patients with long QT or patients that are taking medications that prolong QT, such as some of the antiarrhythmics or antibiotics. Macrolides and fluoroquinolones are real common. Always do the interaction checker. Hippocrates has a great one that you can put in, before you go adding a bunch of medicines. Make sure that they're not already on something that would prolong the QT. It's contraindicated in patients with severe liver or kidney disease. It decreases the occurrence of AFib, and it slightly decreases A1C. So it might be good for a diabetic. And again, it's not used for acute anginal attacks. This is a preventative, like beta blocker. It's hopefully going to reduce their number of attacks and kind of keep them under control. Calcium channel blockers are considered third-line anti-ischemic drugs for most post-MI patients because they can increase ischemia, and they also increase mortality rates. So, I, as a nurse practitioner, I'd let the cardiologist be the one to decide to put them on that. Now, we're going to talk about Prinz metals, and that's a little bit different because calcium channel blockers are used for them, but they don't have ischemia. They should also be avoided in patients with heart failure with reduced ejection fraction because they increase mortality in that. If none of those are present, then ditilazam, verapamil, amlodipine, nifedipine, and bicardipine are approved for use in angina with the above cautions. So this would be somebody, that can't take anything else. I mean, you've tried everything else and it's not working. But, as a nurse practitioner, I wouldn't be the one to do that. I'd let the primary care or the cardiologist decide on that. Platelet inhibiting agents, unless contraindicated, daily aspirin should be given to all patients with angina, and Plavix or clopidogrel is recommended as an alternative to aspirin if they're intolerant to aspirin, have an allergy or something, or have GI bleeding that they can't take it. In stable angina, and in addition to aspirin in patients with acute coronary syndrome who have undergone stent placement. So, they've had a stent, they're probably going to be on those two anyway. So aspirin and Plavix. And then obviously risk reduction. You want to do aggressive risk modification, statin for their dyslipidemia, treat the hypertension to goal, smoking cessation, exercise and weight loss plan, all of those kind of things. Revascularization. Who should undergo revascularization for angina? Patients with unacceptable symptoms despite adequate medical therapy. So you've given them, thrown every drug in the book at them, and they're still having pain. Patients with left main coronary artery stenosis of greater than 50% with or without symptoms. So if they, do that catheterization and find that, they're going to go ahead and revascularize them. patients with 3-vessel disease and left ventricular dysfunction, ejection fraction less than 50%. Patients with unstable angina who, after symptom control with medical therapy, continue to exhibit ischemia on exercise testing or monitoring. Post-MI patients with continuing angina or severe ischemia on non-invasive testing, and patients with acute myocardial infarction and ST elevation. So this is, the one you're going to do, send them right from the ER to the cath lab. Methods: percutaneous coronary intervention with stenting. So that's a balloon angioplasty, where they're going to go and do a cardiac cath and put a stent in, open up the vessel with the balloon and then put the stent in. Or open surgery, traditional open or minimally invasive coronary artery bypass grafting. Okay, this is in your book, and I don't have the page number, but this is the algorithm, and it's too small to see on here, but look at this algorithm in your book, and it kind of goes through the whole thing. You've got stable ischemic heart disease. If I do that, I'm going to, shouldn't have done that because then I mess it up. Great. I got to try to figure out how to undo what I just did. No, I lost. Okay. Let me see if I can. I was trying to increase that for you, but now I lost my. I lost the right-hand column, so I can't see your text. Let me see what I can. I'm making it worse. Okay, let me see if maybe going to the next one will work. Okay, so we talked about revascularization. And so that chart you can look at in your book, and it talks about, it's just kind of an algorithm starting with stable ischemic disease, give them the aspirin, give them the clopidogrel if they've had an MI or a stent, treat their anginal symptoms with sublingual nitrates, use a beta blocker, use different things. So look at this in the book, and hopefully that will. I don't know how to. I have messed up my screen, guys. The joys of. Nope, not it. Okay. Get there. Maybe it's. Let me try to resize. I'm sorry about this. Let me try to resize some of these. Okay, it's on page 367 of Mgmt. Thank you, Lauren. Okay, so does the screen look messed up to you guys too, or just me? Oh, darn it. Okay, so it's just mine. So hopefully I can get through this in the next 10 slides. But okay. Oh, sorry. Okay, so now we're going to talk about coronary vasospasm and angina with normal coronary arteries. And this is occurs in 2 instances, cocaine and Prince-Metal. So we talked a little bit about cocaine already. Cocaine is a very potent. Hang on, let me put something on so my dog will stop barking at you. Come here, Brady. I'm going to get the egg out. No barking. You're staying here. Come on. Come stay down here by me. No barking. Sorry. Okay, so cocaine is a potent vasoconstrictor, and it causes coronary vasoconstriction with anginal chest pain, even if they don't have any blockage. They have normal coronary arteries. They're just taking a drug that's squeezing those arteries shut. You suspect this in a sudden onset of chest pain in a young adult without risk factors for coronary artery disease. So always ask about use of illicit drugs and test them if you need to. And then Prinzmetal's angina is chest pain that occurs without the usual precipitating factors such as exercise. So this, kind of comes out of the blue. Sometimes it often occurs in women under 50. It may occur early in the morning or awaken them from sleep, which is very different than typical angina that occurs with activity. It's associated with ST elevation instead of depression. Usually you see ST depression on a EKG of a patient that's having angina, and in these you see ST elevation instead. And they may have associated arrhythmias or conduction defects. The treatment, you want to do coronary artery angiography, so do a cardiac cath to see if they have any fixed stenosis or blocked vessels. If that's positive, then you're going to treat that with revascularization or aggressive medical treatment. If no fixed stenosis is found, so their coronary arteries are normal, then you can treat them with nitrates, which vasodilate, or calcium channel blockers, which sometimes help that spasm. So this is the only time that calcium channel blockers would be more common to use, because they don't have they don't have a stenosis that's causing the ischemia. You want to avoid beta blockers if there isn't any stenosis there, because they can worsen the spasm, just like they cause bronchospasm. You don't want to give that. And avoid triggers such as smoking and obviously cocaine, which is easier said than done. So that's Prinzmetal's, and that's just kind of a variant of angina that you see in somebody that just doesn't really fit the profile. They're either young, healthy drug user, or the 46-year-old woman that wakes up in the middle of the night with chest pain. So now we're going to move on. So can Prinzmetal's be diagnosed after a clean cath? Yeah, if they did the cath and there were no stenosis, but they're having the symptoms, and they would probably do maybe a Holter monitor or EKG or something to try to catch that ST wave elevation. But a lot of it would be depending on history, how the symptoms occur, when they occur, and then also getting the cardiac cath and seeing that they don't have stenosis that's causing the ischemia. So, there's not too many other things that can cause ischemia, cardiac ischemia. If there's no stenosis, then it's got to be vasospasm. Okay. So, again, we talked about stable angina, unstable angina, and acute coronary syndrome as being on a spectrum or a continuum. It's not just, it's basically one disease in different severities. So now we're going to talk about acute coronary syndrome. So it can range from unstable angina to acute myocardial infarction. With unstable angina, you can have unstable angina, you can have non-ST elevation myocardial infarction, which they call a non-STEMI, or you can have ST segment elevation myocardial infarction, that's called a STEMI. And patients may go from one stage to the other as the ischemia improves or worsens. So, they can start out with non-ST elevation and then progress to ST elevation. So, these patients are going to be in the hospital. It's important to distinguish between a non-STEMI and a STEMI at presentation to decide if they need immediate reperfusion therapy. And you have the EKG book that you're supposed to work through this summer, and some of you probably have done EKGs before. What is the significance on EKG of some of these, like T-wave inversion? Anybody know what T-wave inversion means? The T-wave inversion is ischemia, and that can be transient or, so usually when they have transient ischemia, you see that. ST depression, see that as much in the hospital. This is usually due to diminished coronary blood flow, and it can be seen in angina. Sometimes you'll see it on stress tests, and you can see it in subendocardial infarction. ST elevation, what's that one? That's the one you see when somebody's having a heart attack. So that is injury. That usually indicates an MI. It can be, but you can also see transient ST elevation that only lasts a few minutes in Prinzmetal's. We talked about that, but it's not, due to ischemia, to ischemia. And then Q waves. What do Q waves signify? You can see them in an old MI, but what is it? What causes the Q wave? What happens to the heart that causes the Q wave? Absence of electrical activity, because what happened to that part of the heart muscle? Necrosis. Okay, that part of the heart muscle has died. It's not just ischemia at that point; it's death. So you don't see them, in the first few hours. You see them after a couple of days, and that they signify necrosis of the cardiac muscle in that area, and that. So if you see new significant Q waves, that is diagnostic of acute MI, because that area of the heart has died. Okay. Everything else kind of, you can have ST elevation that goes away because Prinzmetal's goes away. You can have ischemia that goes away, but Q waves are cell death of myocardium, and that's by definition is an acute MI. What was T wave inversion? T wave inversion is just ischemia. So those are some of the things that you'll be looking at in that EKG book. So this is normal EKG prior to an MI. You've got your QRS. You really don't have any Q. You've got RS and a T wave. This is a peaked T wave or high amplitude T wave that you sometimes see with ST elevation. See how the ST segment's coming off the baseline. This is marked ST elevation. That's that widowmaker with a hyperacute T wave. This is, again, ST elevation, and this is a Q wave down here. So see, they're starting to develop the Q wave here, and they've got the T wave inversion. Here again is a Q wave and T wave inversion. And then this one is just Q wave. And once Q waves are there, they're going to stay there for usually the rest of the life of the patient. So that's why you can see them on an EKG if somebody had an MI a long time ago. And then the T waves will eventually revert to the upright status. None of you have this slide because I put it in about an hour ago. I'm sorry. I'll send just this slide, or I'll put this slide in the forum or something, okay? Okay, so signs and symptoms: chest pain at rest or with minimal exertion, usually substernal, but can radiate to the jaw, left arm, shoulder, or even both arms. Pain is usually lasted more than 30 minutes. Remember that 30% of patients with acute MIs have no chest pain. They tend to be elderly, women more common, diabetics because of neuropathy. They're not feeling that pain. More common. They have they have a higher mortality because they're not going to get worked up. So sometimes they'll just say they don't feel well. They'll come in with severe fatigue or dyspnea, but they're not complaining of chest pain. Nausea, dyspnea, diaphoresis, anxiety, and syncope are all common symptoms of acute coronary syndrome. Lab tests. Again, this is just, I do want you to know this, but I want you to know what can happen. So, but we're not going to go into a lot of the treatment of this. Lab tests, CKMB, troponin, or high-sensitive troponin, those are all cardiac biomarkers that rise when there's myocardial cell death or injury. They can be elevated in other cardiac conditions like heart failure, but the timing and the rise and fall is very well documented in acute MI. I'll show you that in the next slide. So serial levels are drawn. Usually draw them at, presentation at 3 hours, at 6 hours, and they do serial levels to look for that rise and fall of the troponin. EKG, you may see ST segment depression, ST segment elevation, peak T waves early, then flattening or inversion of the T waves, new bundle branch block, and the development of new Q waves. So this is the troponin in myocarditis. It's just kind of a very gradual rise and fall. In heart failure, it's just a little bit elevated and it just stays kind of flat. You just constantly have a little elevation. But with an acute MI, it rises very quickly over the first few hours and then slowly goes down. So, this is what they're looking for. So definition of myocardial infarction is a rise in serial cardiac biomarkers with at least one value above the 99th percent of the reference range, together with evidence of myocardial ischemia, so they have the symptoms of ischemia, the pain, things like that. EKG changes showing of new ischemia, the ST elevation, things like that. Development of new Q waves, imaging evidence, if they do a echocardiogram or something that shows new loss of viable myocardium, and development of new wall motion defects. Sometimes they'll do an echocardiogram and they can see that one part of the left ventricle is not moving normally because that part's died. I'm just having all kinds of tech problems today. Okay, treatment. I'm not going to test you on treatment of acute MI. You need to know, how it presents and the symptoms and everything and what you would originally work up, so that if you are working in a acute care or ER in the future, which some of you will do, or if they come to an urgent care or something, you know what to do. But I'm not going to test you on the treatment of like the reperfusion and anticoagulation treatment. I will test you on the treatment that they're going to continue on discharge, and we're going to go over that. So non-STEMI is just going to be antiplatelet therapy with aspirin and P2Y12 inhibitors like Plavix or one of those. Sometimes glycoprotein 2B3A inhibitors are used in high-risk patients. So antiplatelet first, anticoagulation, heparin, factor XA inhibitors, and direct thrombin inhibitors. Those are all your Eliquis and all of those things. And so those are the two mainstays, the antiplatelet and anticoagulation. Fibrolytics are not going to be used since the patients don't have coronary occlusion, and the risk outweighs the benefits. Selected early angiography with revascularization is done if they think that's going to be beneficial. And then a STEMI, which is the ST elevation MI, antiplatelet therapy, so you're going to do aspirin plus the P2Y12 inhibitors. You're going to do fibrolytic therapy with a goal of 30 minutes from arrival at the ED, followed by anticoagulation if PCI is not readily available, and then reperfusion therapy, going to the cath lab to do balloon angioplasty and splinting with a goal of 90 minutes from the first medical contact with PCI and splinting. And that is superior to fibrolytics. So sometimes if they go, come to the ER of a hospital that's got a cath lab and they've got a team there, then they go right to reperfusion. They don't do the fibrolytics there. Okay, so this is the stuff you do need to know, though, and the stuff in your book where it says general measures under after the MI. Post-MI care for all patients, aggressive reduction of risk factors, smoking cessation, weight loss, treatment for obesity, aggressive management of other conditions such as hypertension and diabetes, get their A1C within goal, get their blood pressure down to goal, cardiac rehab or supervised exercise program, nitrates or ranolazine for angina relief. High-intensity statins should be initiated on all patients unless contraindicated. And then beta blockers are shown to decrease mortality, especially COREG. If heart failure is present, you're going to have to wait until they're stable and the fluid overload is corrected. We're going to talk about that more next week, and then give the beta blocker. But beta blockers are going to be a first-line treatment as long as they're not in decompensated heart failure. Long-term antiplatelet therapy with aspirin and Plavix or Brilinta. The duration is going to depend on the type of MI and what interventions were already done. You know, if they have a drug-eluting stent or what type of interventions they did, but they will be on some type of antiplatelet therapy long-term. ACE or an ARB should be continued indefinitely if they have left ventricular dysfunction, such as ejection fraction of less than 40%, and in those with hypertension, diabetes, or stable CKD. So if they have, you know, most of them are going to have hypertension. So beta blockers and ACE inhibitors are going to be good medications to use to control their hypertension because they're, you know, shown to decrease the mortality after MI. Use of calcium channel blockers has not been shown to be helpful and is not recommended. Another reason that I probably wouldn't use them too much in angina because, like I said, it is a continuum, a spectrum, and they can move back and forth. So I would probably be very careful about using calcium channel blockers. And then selected revascularization if they didn't already undergo that. This is outpatient diagnosis of chest pain, and it just goes through kind of an algorithm of, you know, start with chest pain. I don't want to mess with my screen because if I do, I'll never get it back to normal. But, you know, it goes through musculoskeletal, you know, what are the most likely? Is it musculoskeletal? Is it GI? Is it psychiatric? Is it cardiac? And if it's cardiac, you know, you follow different arms down and do the different treatments that we just talked about. And you post that in the form as well. Yeah, is it too hard for you? Is this one not in your slide pack? It should be on your slides, and you can increase the size of your slide on your screen without messing up. If I do it, I'll take out the, yeah, you'll have to blow it up because it's really kind of, if I post it again, it's still going to be small. But I'll try posting it just as a Word document. Maybe it'll be bigger. So I'll post that and that other EKG thing in the form. Okay. And that was the end. So questions. We went over a lot of stuff, I know. Any questions? Okay. Yeah, Lauren said if you click the arrow, it will download the current presentation, and it has all those slides in it. Okay, so if there's no questions, then I'm going to go ahead and log out. We're going to have another big blue button next Monday on heart failure, because that's another big topic that you see, or another big condition that you'll see a lot in primary care. Someone asked, do you need to know the numbers for healthy heart? That one, of course, it's probably changed because I don't even know what the blood pressure on that one is. You know, blood pressure keeps changing year by year, whether it's, you know, 140 over 90 or 140 over 80 or 130 over 90. It keeps going back and forth. So I'm not going to test you on that document. You should know what the risk factors are. And, you know, you should know that, you know, cholesterol should be, you know, LDL should be under 100 or under 70 if they have coronary artery disease, that blood pressure, you know, should be somewhere in the 130 over 90 or lower range. That their A1C, you know, should be normal. Their blood sugar should be under 100, you know, fasting blood sugar, all those kind of things. There will not be any rhythm strips on this exam. We used to do it on the final, but now you'll have a EKG interpretation workshop during your second intensives when you come in the fall. So, but you're going to see a lot of EKGs in clinic this summer. I hope you will. Ask to see them if you can, and ask your preceptor to go over them with you. But go through that book, start working. It's a self-study workbook, and start doing that, and then looking at as many as you can, because that's the only way to learn them. Any insight on how in depth we need to get on murmurs? You should be able. There's a chart in the book. Hang on, let me grab the book. There's a chart in the book. The Khan Academy videos, those are great. I listen to those myself. Let me see where I think the chart in the book is at the beginning of the chapter. Yeah. It's table 10.2, and it goes through different murmurs. It goes through location, timing, character of the murmurs. If you just look at that, and so that you would know, mitral stenosis, mitral regurgitation, aortic stenosis and regurgitation, and tricuspid stenosis and regurgitation, it tells you where the murmur is going to be, the timing, and the character. I would know that because, it is a huge chart, but I'm not saying to know everything else, but you should, try to understand what the different murmurs are going to be for the different valves, for regurgitation and stenosis for the major valves, because that's what you're going to be seeing in clinical. Like some of them, where do they radiate? Sometimes they radiate to the carotids. You think you're hearing bruits, but you're really hearing a murmur of regurgitation. Okay. Watching the Khan videos makes the chart less scary. Yeah, and open the book, have that chart in front of you while you're watching them, and then you can listen to it and say, okay, now that's what because just reading it in text is kind of hard. That's why listening to it and the way he explains it, I think, is great. Yes, timing is systolic or diastolic. That's what timing represents. They'll say, mid-systolic, like mitral valve prolapse. They'll say either a systolic ejection murmur. It's usually called a mid-systolic click, things like that. Okay. Any other questions? Okay. Well, I'm going to go ahead and sign off. And if you have any other questions, you can put them in the forum, and I'll answer them there. And I will see you again next week. Thank you.